well hydrated fruit here and a fruit with some problems with hydration.
One on the left, I mean on the right, that has problems with hydration.
Okay, so pretty much similarly when we deal with our patients, okay, that's the kind of texture that we're looking at when we say skin texture. Okay, we're looking at the texture of the skin. Okay, and it can mean a lot of things, not just for hydration purposes, but it could be age related as well. It could be the age, of course. Okay, we're going to be dealing with the older adult population. Okay, and I'm already one of them, so some of these wrinkles are starting to show up on my face as well. Okay, so but that's inevitable. Okay, everyone has to go through that stage. So, based on the definition of um, just some, again, just a few technical terms, okay, the National Pressure Ulcer Advisory Panel, or the NPUAP, okay, has announced that the term pressure injury will be used to replace the former term pressure ulcer. But in real practice, again, this is still a very commonly used term, pressure ulcer. Okay, well, we're trying to deviate from the using the term, okay, especially in the aging system of a pressure related injury. Okay, because if you think about it, the word ulcer, what does the word ulcer mean? When you see the word ulcer, gastric ulcer,
A hole of some sort.
it's like an open sore, right? So it's like an external, it could be external, it could be an internal part of the body that has an opening or a hole, as what John was saying. Okay, so this can be caused by a break in the skin or the mucous membranes that fails to heal. Okay, so you can have ulcerations in your mouth. Okay, and again, that's a very non-specific term. So that they wanted to change the use of the terminology, and we're still trying to educate a lot of people on how to really stick with the proper use of the terms. Okay, so um, a more acceptable really when you want to refer to an injury that is caused by pressure is to name not to call it not as a pressure ulcer but as a pressure related injury, okay, or a pressure injury. Okay, so there's more specificity on the definition of the term. Okay, um, in terms of the nursing process, again, most of the patient problem here, if we're going to use a nursing diagnosis here, would be a compromised skin integrity. Okay, and this can be an actual problem, meaning it's already existing in the patient, or it is a risk for a problem for the patient, meaning the skin's still intact, but because of the condition with the patient, that puts him at risk for developing a pressure related injury. Okay. And this is what we commonly see in terms of making a nursing diagnosis to someone with a skin problem, a break in the skin, or skin injury. Okay. And again, this is a general nursing diagnosis. So prevention and treatment of skin impairment is one of the nurse's highest priorities of care. Okay. You don't want to be caught with someone developing a pressure related injury under your care. That's a big incident. Okay. So you expect to see a lot of visits from the state. Okay. From the state board, if someone is reported to have developed a pressure related injury during admission. Okay, that's something that a lot of the bosses doesn't want to occur in their facilities as well. Okay, this is pretty big because why do you think is the reason? Why is this pretty big? If someone develops a pressure related injury, what could that mean?
It means that they weren't changing their bed positions enough.
They're not being taken care of properly, right? It could be a form of neglect. Okay, and in some cases that can even be not just negligence, but it can be also what is a more serious case that you can face that's more serious than negligence. It can be a malpractice. Okay, you can be charged with a malpractice for someone who develops a pressure related injury under your care. But there are definitions, of course. Okay, um, and then currently we have about 2.5 million. Okay, on the last count. of hospitalized patients developing pressure injuries each year. Okay, despite all the guidelines that we set, all the care plans that we set for these patients. Okay, there are still a high incidence of people developing pressure related injuries. Okay, so in the acute care facility, okay, it's not just a long-term care facility, but even in an acute care setting, okay, people do develop these types of problems. Okay, so what does it mean? That means that the patient has longer hospital stays. Okay, so that mean that this would end up more cost for them. Okay, with their hospitalization. Okay, what else? What other complications are we thinking of? Infection. Okay, once they develop this pressure-related injury, that increases their chance of also contracting some types of infection, okay, to the pressure injury. Okay, so and the bottom line there is, instead of keeping the patients maybe for 5 days, now the patient has to stay maybe for a longer period of time because of the new problem, right? So a good nursing intervention can result in, number one, the optimal healing of the impaired skin without complication. Okay, a decrease in the patient's discomfort. This can be painful to some of them. A decrease in the length of stay in the facility if a discharge is planned. So if the patient is being planned for a discharge to a home setting, okay, then that would delay the process, of course, if they develop this problem. And of course, a decrease in the cost of ongoing care. Okay, and this can be detrimental on our patients as well. All right, so going back to that nursing diagnosis of impaired skin integrity, whether actual or risk for, okay, this is when someone develops a pressure-related injury. This is considered as a major manifestation, okay, and most of the problems would relate to this nursing diagnosis is really pressure-related injuries, okay. So that means if the patient stays in one position without relief of pressure, okay, especially on the bony prominences, okay, there is a more likelihood that that patient will develop a pressure-related injury, okay. So what causes this? Okay, so when there is sufficient pressure that is being exerted on the skin, that causes the blood vessels to be interrupted, the flow of the blood to be interrupted and collapse, okay, that leads to an injury. Okay, so a lot of times, if you're going to watch for patients who have these types of injuries, most of them they develop in areas where there are bony prominences. Okay, what do you think is the most common area where you have seen this? For those of you who have worked on the floor, where do you usually see these pressure-related injuries?
Your coccyx.
The coccyx, which is number one. Okay, that's the number one site of a pressure-related injury. What do you think is the second? That would be the heel on the foot area. Okay, so if a patient has been side lying, now looking at the anatomy of the body again, which do you think would be where areas would be the bony prominences are? And that's what we're going to be learning from this topic as well. Okay. So pressure injuries, these are localized injury to the skin or the underlying tissue, usually over a bony prominence, okay? And this occurs when sufficient pressure in the skin causes the blood vessels in the area to collapse, okay? We're thinking about the smaller blood vessels, which is what? What are the smallest blood vessels in your body? Anyone? So you have the artery, the arteriole. And it goes to what type of complex system? After the arteriole, what follows? You have the capillary system, and this is where how the blood flows from the heart, goes to the artery, to the arterioles, to the capillaries, and then goes to the venules, and then the veins, and then back to the heart, pretty much, right? So the most sensitive areas here would be pretty much those blood vessels that are single cell layer, and those are your capillaries. So when you put pressure, okay, it's very fragile that an extended amount of pressure exerted on those capillary beds, okay, can cause them to collapse, and that would cut off the circulation, okay, and that's where injury would occur. So Again, this is evidence based, and they found out that if pressure continues for 2 hours without relief, cells in the involved layers of the skin tend to undergo necrosis. Then this can be irreversible. Okay, when the cells become necrotic, now it's a big problem because pretty much now we may not be able to reverse it. If we are able to move our patients within that 2 hour time frame, okay, we can prevent the cells from going into a necrotic state or from dying. Okay, so that's the principle behind it. If you're asking why do we have to move our patients every 2 hours, okay, because within that 2 hour time frame we can still reverse the problem. We may still be able to reverse the problem. So relieving pressure on those pressure points, the bony prominences, within that 2 hour time frame can greatly minimize the occurrence of pressure-related injury. Okay, so the most common site, again, we said it was the sacrum, and you are right on it. Heels being the second. Okay, and then there are two mechanical factors that's causing this pressure-related injury. It's the shear force, okay, and when you drag someone, okay, that can also cause a problem in the skin integrity of the patient. So friction and shear force. All right, let's look at the main distinction between the two. So these are the two mechanical forces. The first one, when we say the shearing force, okay, so this occurs when the tissue layers of the skin slide on each other, okay? So on the picture on the right, where do you think would be look at the picture at the bottom where the buttocks area of the patient is, okay? So there's an opposing force, okay? One is going down and one is going upward, pressing. So you can just imagine if there are multitude of blood vessels in that area and you're exerting a lot of pressure because maybe the patient is being improperly positioned or the patient is not being properly repositioned every 2 hours, okay? That can result to an interruption on the blood flow. Okay, so if I put your focus on this area where I put a circle, okay, that is caused by shear force. Okay, a lot of times, most of the pressure-related injury are caused by the shear force. Okay, not by the friction, but they go hand in hand. Okay, the friction is something to do also with a problem in the skin integrity of the patient. Okay, so and that is the second mechanical factor. So the rubbing of the skin, okay, so this time for friction, it's the rubbing of the skin against another surface produces friction. Let's say the bed linen, okay, and the skin of the patient, okay. So that rubbing force, okay, is what we call as friction. Okay. So when you're moving your patients in bed by not lifting them and just sliding them up, because you're too lazy to use the pads to lift them up, okay, that can lead to an injury as well, okay. So that means improperly lifting, if you're not fully lifting them and sliding them up or down the bed when you're doing adjustments in the patients, that can cause an injury as well. But most of the big problem when it comes to pressure-related injury is really the shear force, okay. And then the main difference, again, if you want to ask further, okay, the injury caused by the shear force is deeper in the tissues. You may not see it, okay? So the patient already has sustained an injury and you still won't see it, okay? Unlike friction, if there is an abrasion that developed in the patient's skin, we can visually see the damage or the injury, right, with friction. Friction is more superficial, okay? So the deeper tissues is what we're concerned about, okay? Because those are the things that we don't see right away. It starts with a reddened area, and then it proceeds to a more serious state, all right? So this is the transition when the patient starts to develop a stage 1 pressure-related injury, going to stage 2, a stage 3, and a stage 4, okay? And I want to clarify this. The only ones that we will be staging are pressure-related injury. So if you have a cut, you have a laceration, you fell on the ground, you had some multiple abrasion in your skin, we don't stage those. All right. If you had a surgery done by a physician, we don't stage those wounds. The only wound that we stage are those that are pressure related. Okay, so let's be very, very clear on that one. So here, what you will see on a stage 1, the skin is intact. It's unbroken, but you will see some redness. Okay, and when you put pressure on the redness, okay, it does not change its color. It stays red. Okay, we call that as a what? Non-blanchable erythema. It doesn't blanch. It doesn't turn pale. Okay, that is one distinction between another type of tissue injury. If it's pressure related, stage 1, intact skin, I do a blanch test, I put a pressure in the affected area, it stays red. Okay, even when the pressure is applied. Typically, and you can try this on your skin. Okay, put pressure on your skin, it will turn pale. If you let go, the circulation goes back. Okay, it goes to your original color. Okay, that is what we call as a blanching test. Okay, so a non-blanching erythema is considered as a pressure-related injury. That can be a sign of stage 1. Okay, do you have any question on that one? I'll try to go slow on this one. I want you to understand this fully. Any question on that stage 1? Stage 1, non-blanchable erythema. Erythema is redness. Okay. Stage 2, okay, 2 things can happen. The skin may be intact, but there is the presence of a blister. A blister meaning there is a fluid-filled area. Okay. Or the blister can break and the skin starts to erode. Okay. So when the layer, okay, only reaches the level of the epidermis or the dermis, okay, we call that as a stage 2 pressure-related injury. Okay. I'm gonna pause. I want to make sure you're following me. Are you able to so far so good? Okay, I do have a lot of questions on this part. I don't want you getting confused which one is stage 1, stage 2, stage 3. Okay, so now we go deeper. Then the injury goes towards the fatty layer of your skin, the subcutaneous or the adipose tissue. Okay, well, now we call that as stage 3, pressure-related injury. If you start seeing bones, muscles, or tendons on the sore of the patient, that's a very deep injury. Now we call that as stage 4. Okay, so extends towards the muscle, the tendons, or even the bones. So in some patients, you might see the bony areas, okay, especially in the coccyx. Someone with a stage 4, it looks nasty. All right. And I did discuss this to you. So let me just, my resources are getting slow. Let me turn off my video real quick. All right, we have the dermal papillae. I did discuss this already earlier. Okay, I didn't realize I have this in my slide. Okay, but this is what's holding the dermis and the epidermis together. Okay, if the skin slips, this is what prevents it from slipping apart. So it's not separating. Okay, so even if we rub it vigorously, our skin, okay, it's not gonna separate. It's the dermal papillae that's holding it together. But when it becomes repetitive motion or actions, like in the case in the lower left picture, okay, for those people who love to, those pumps, okay, after hours of using it, walking with it, okay, they start to develop a blister, okay. That means you have compromised the integrity of your dermal papillae, okay, that caused the separation of your dermis and your epidermis. And because of this, that leads to a tissue injury. Now your body went into what we call as an inflammatory response. You start to swell up. Okay? What causes the blister here is really the dilation of the blood vessels. Okay? Your capillaries during the inflammatory process, they tend to become leaky. Okay? They would leak the fluid from your blood. blood circulation, and it will go to the injured site. Okay, this is beneficial in a way because it helps with the healing process, but also what causes the accumulation of this fluid is really the movement of your albumin, the protein part, from your blood circulation into the injured site. Okay, and the albumin has what we call as a pulling pressure. They can exert a pulling pressure towards the fluid part of the blood. So that means water will follow when protein starts to leak out of your capillaries. Okay, water will follow through it and leads to the accumulation of the fluid. That's now you have that blister. Okay, um, just like salt. Okay, it has a pulling pressure in water, so water follows salt. Okay, so typically again, okay, for normal patients, okay, your albumin, which is the most abundant protein in your blood vessels, in your blood circulation, usually it doesn't leak out. It's too big to leak out of the capillaries. Okay, but during the inflammatory process, the capillaries become more leaky. Okay, that allows these proteins to leak out, and it's pulling the water out itself. That's what's causing the swelling in any type of injury, whether it's a burn, a cut, or an infection. When your body becomes swollen, okay, it's the dilation of these blood vessels. All right, but there's a good purpose for that because white blood cells can come in, okay, and white blood cells, we know they have phagocytic actions. They can pretty much eat all the dead tissues in the injured site. That would help in the healing process. Plus, they can deliver antibodies to usually prevent the wound from getting infected. And this is also the reason why every time you cut yourself, it doesn't usually always get infected, right? Okay, it's your own immune system that's working against it. Okay, so this leak of fluids there brings these antibodies to the injured site, and usually when there's a high level of these antibodies in the injured site, they tend to fight infection better. Okay, so a lot of times, a lot of us, unless you're diabetic, okay, when we develop a cut or a wound, you don't even have to put antibiotic. It heals by itself. Your body repairs it. Okay, so that's the concept here. All right, let's look at the most simple way of about pressure sores or pressure related injuries.
Pressure sores, also called bed sores or decubitus ulcers, are regions of skin that break down when you sit or lie in one position for too long. These wounds occur most frequently in areas where your bones are close to the skin, including your heels, ankles, hips, tailbone, or elbows. Constant pressure to one of these areas compresses the blood vessels that supply your skin with oxygen and vital nutrients. Without a sufficient amount of blood flow.
And this is really a good representation of your capillaries. Okay, your capillaries are so small, okay, that it would only allow a cell of a red blood cell perhaps to flow into it. Okay, they form a line. Okay, that's how small your capillaries are. Okay, so this is really good representation on how the cells in your blood would flow in the capillary level.
Your skin cells eventually die, and a pressure sore forms. Pressure sores are categorized by degrees of severity. A stage 1 pressure sore is reddened, inflamed, and does not blanch or become pale when pressure is applied.
All right, it doesn't blanch. Okay, usually if you put a pressure on your skin, it will turn pale, and if you let go of the pressure, it returns to its original color. A suspected stage 1 pressure-related injury, when you put the pressure, it doesn't turn pale, it doesn't blanch. That's what we call the deblanching test. Okay.
A stage 2 pressure sore appears as a blister or an open sore. The area surrounding the sore may be red and irritated. A stage 3 pressure sore involves...
All right, how deep is a stage 2 pressure injury? Up to what level is the depth of a stage 2 pressure-related injury? Okay, so dermis and epidermis. Okay, When it goes to the subcutaneous layer, what do we call that now?
Stage 3.
That's 3.
Involves a full thickness loss of skin that appears crater-like and extends to the layer of fat beneath your skin. Stage 4 is the most severe. A stage 4 ulcer is a full thickness wound that extends down to the underlying muscle or bone. In 2007, the National Pressure Ulcer Advisory Panel added 2 more ulcer stages: suspected deep tissue injury and unstageable. Suspected deep tissue injury is a maroon or purple area of the skin and may contain a blister filled with blood. It looks like this because of damaged soft tissue underneath your skin.
All right. So again, to minimize your confusion, and this is not really easy, this is not hard to learn, okay? As stage 1, you're not going to see this color, okay? Because in a suspected deep tissue, or SDTI as we would call it commonly, okay, what you would see in the color of the skin is some purplish dark red discoloration on the affected area, okay? In a stage 1, it's purely red, okay? No purplish discoloration. That's the major distinction, because if you look at the skin of someone with a suspected deep tissue injury, its skin is intact, no break on the skin, okay? But you have that purplish discoloration. That is scary, okay? Why? Because that tells you that the injury is way deep, okay? That means if you break the skin on this patient with SDTI, it could be automatically a stage 3 or stage 4 pressure ulcer already. Okay, so that's how serious the problem is. The only bad part is, the only way we can distinguish it is the discoloration in the skin as well. Okay.
An unstageable ulcer is a full thickness loss of tissue. However, the amount of tissue loss cannot be determined because the ulcer is covered by dead tissue. To prevent infection in your pressure sore, your doctor will clean your wound using water and a mild soap or saline solution. If your wound is severe, your doctor will debride or surgically remove the dead tissue from the pressure sore. To protect and hydrate your wound, your doctor may cover it with a specialized bandage.
All right. Quick way to learn that one, okay? A very short video. All right, let's look at the pathophysiology and the etiology of a pressure-related injury, okay? So again, it's localized, okay? It's localized injury to the skin and or the underlying tissue, usually over a bony prominence, okay? That is an important defining factor when you're dealing with or assessing a pressure-related injury, okay? Or as a result of pressure or pressure in combination with shear, okay? So pressure ulcers generally fall under the category of healing by secondary intention, okay? That means this is going to be a delayed form of healing, okay? The cuts done when you are undergoing a surgical procedure, the doctors cut you up, okay? That usually heals by what we call as the primary intention healing, okay? Pressure ulcer is not going to heal that way. There will always be a delayed process in the healing. A delay in the healing process of a pressure-related injury. So that would heal by secondary intention healing, okay? And the most common site for pressure, again, sacrum, the heels being second. It can develop in other parts of the body where there are bony prominences as well, okay? So possible select all that apply here. What are the factors that can influence the development of pressure ulcer? Number 1, the amount of the pressure exerted, that is the intensity. Number 2, how long is the exposure, the length of time the pressure is exerted on the skin, that is the duration, okay? And we said that if it goes beyond the 2-hour period, that damaged tissue can lead into a tissue death or necrosis, all right? Number 3 factor is the ability of the patient's tissue to tolerate the externally applied pressure, okay? That means this can be, again, unique in every patient that we deal with, okay? There might be patients who can tolerate longer periods of pressure being exerted on the area, so with no injuries happening, right? So other factors that contribute to pressure ulcer formation, including the shearing force, okay, and also the excessive moisture. This is where we come in again, Is the patient incontinent to urine or feces? Okay. An extended exposure to fluids can lead to the maceration of the skin. They become more easily damaged. Okay. So excessive moisture exposure. Okay. And that is why important that for nurses, and you always have to direct your CNAs, monitor the patient who are incontinent to make sure that their incontinent brief is always maintained dry. Okay. So who are at risk as well? So older population, the incontinent patients, if the patient is bedbound or unable to reposition themselves, okay, or if they're unaware of the need to reposition. Sometimes they enjoy watching a show and they're staying in one position for an extended period of time. That can be a risk factor as well. Or people with spinal cord injury who are not able to move independently. Okay, uh, patients who are dependent on wheelchairs. Okay, so a lot of these people are also people with problem in the spinal cord. Okay, so going back to this intention, you will learn this when you go to your chapter. Have you guys discussed the surgical wound care? Not yet.
Not yet.
Not yet. Okay, you will learn more about these stages of healing when you go to the surgical wound care. Okay, but for now, what you will remember, okay, so and when the injury, okay, is caused by a clean laceration, okay, or a surgical cut, okay, or maybe a surgical incision performed by a doctor, okay, and they were able to close it with maybe sutures, staples, or steri-strips. Those types of wound would heal by primary intention healing. Okay, so what is the main difference between the two? Okay, when we say approximate, if this is the wound edge, okay, if I have a deep laceration, the skin would open this way, right? This wide, right? If I'm able to close it together, both edges of the wound, if I'm able to close it together instead of open like this, okay, by stitching it or suturing or stapling it, okay, that would heal in what we call as a primary intention healing. A pressure injury, okay, especially if you look at the shape, it's round, okay, there's no way that you can join the edges together, even if you suture it, okay, it would cause a lot of deformity, okay. So what the doctors would do is they would let the cells develop. That's what we call as granulation until it slowly closes itself, and when the granulation is at the top of the wound, okay, it would be able to re-epithelialize on the upper part of the skin. Okay, this is the main difference. If I am able to close it together using a suture within 48 hours, okay, the re-epithelialization of the cells will be completed. That is the assumption there. Okay, that is why when you have a surgical patient, it is always safe to assume that the patient can take their shower after 48 hours. Okay, that is on the assumption that the re-epithelialization of the cells has been completed. Okay, so again, if this is the wound, right? If you have a gaping wound right here, okay, if we are able to approximate it, meaning we were able to join the edges together by sutures, okay, this would heal in primary intention healing. A pressure-related injury is shaped like this, okay? So it's difficult for the doctors to have these edges joined together like this, okay? So what we would do, the clinical approach here, is to let the granulation tissue grow on the bed of the wound, okay? And then when it fills up the wound bed, eventually, okay, if this is the wound again, there will be re-epithelialization. The epithelial cells will start to divide, okay, on the very top, okay, and that's where it would be covered, and that's what we call is when the wound starts to heal, okay. So the re-epithelialization of the cells has been completed, all right, okay. So for a surgical wound, within 48 hours, this re-epithelialization will be complete. That means it's sealed. There will be no entry of fluids or bacteria. That is the assumption there within the 48-hour period. Okay, so that's a little bit different. So with secondary intention healing, as in pressure ulcer, okay, it would take time for the wounds to heal. Okay. Any question again?
I had